Welcome, everyone. Happy Wear Red Canada Day. We are coming to you live from across the country for this webinar on our Women's Heart Health Atlas, Chapter 9, which is the final chapter, Lessons Learned and Recommendations to Ensure Equitable Care for Women with Cardiovascular Disease in Canada.
Hello, everyone, and thank you so much for joining us. So in her book, Brady and Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants, Dr. Robin Wall-Kimmerer reflects on the meaning of land to Indigenous people and rights. In the settler's mind, land was property, real estate, capital, or natural resources, but to our people, it was everything. Our identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the source of all that sustained us. Our lands were where our responsibility to the world was enacted. It was sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings that people took with them when they were forced from their ancestral homelands to new places. This is a picture of Half Moon Lake in Alberta, one of the tributaries of the North Saskatchewan rivers. There is evidence of Indigenous people living around this area and using the waterways as the main mode of transportation for thousands of years. I am so grateful that we have the opportunity to share these ancient Indigenous lands. I would like to begin by acknowledging the Indigenous peoples of all the lands that we live on, from coast to coast to coast, including the Inuit, the Indigenous, and the Métis people. We do not have any disclosures, any affiliation, financial or otherwise, with commercial organizations that have any direct or connection with the content of this presentation. We'd like to ask who's joining us today. 25% allied health. We have the highest percentages from people with lived experience. And so thank you so much for joining us in this adventure today. These are the learning objectives for today. So we hope at the end of this webinar, you'll be able to describe or at least think about the current status and challenges and opportunities in cardiovascular care for women and explain the 12 specific recommendations that we've come up with after the whole process of this atlas and looking at the gaps and how to address them and tackle remaining disparities in women's heart health. Cardiovascular disease continues to be the leading cause of death in Canadian women, and sex and gender differences and disparities with respect to cardiovascular disease awareness, development, and identification and treatment persist. The Canadian Women's Heart Health Alliance was established in 2018 with 55 members as a volunteer network of experts and advocates to develop and disseminate evidence-informed strategies. And our point was to transform clinical practice and enhance collaborative action on women's cardiovascular health. It's now grown to over 200 volunteers, stakeholders, clinicians, scientists, trainees, persons living with cardiovascular disease who work together on multiple strategic initiatives, policy, knowledge translation, training, education, and research. The Canadian Women's Heart Health Alliance is aimed at improving clinical care and outcomes for women across Canada. It's currently working on 21 projects that fall within these 5 projects theme. And each project has a project lead, and each theme is represented by a patient advocate co-chair and a healthcare professional co-chair on the executive steering committee. Please visit the Canadian Women's Heart Health Alliance CWHHA.ca to view all the projects and initiatives, and feel free to visit the website for much more information. So in 2018, with our hats in our hands, Sharon Mulvey and I went to our friend and colleague, Dr. Michelle Graham, who was the newly minted editor of CJC Open, to pitch her on the concept of the Canadian Women's Heart Health Alliance Atlas as a vehicle to provide deep dives into each of the gaps identified in our original scientific statement published in the Journal of American Heart Association, called The State of Science in Women's Cardiovascular Disease, a Canadian Perspective on the Influence of Sex and Gender. And it was authored by members of the Canadian Women's Heart Health Alliance. Michelle was incredibly supportive, and as another can-do person, the Atlas was born. This is the roadmap of the Atlas, which is organized into 9 unique chapters. Publication started in February of 2020, and the first 8 chapters have been published. Chapter 9 is published in the CJCO special edition that's scheduled for this month. And each chapter is accompanied by detailed infographics that report on the current state of cardiovascular disease in women. The goal of the Atlas is to help clinicians and women in general recognize the unique aspects of women's heart health and provide policymakers with the information they need to ensure equitable care for women. This is the final chapter of the Canadian Women's Heart Health Alliance Atlas on epidemiology, diagnosis, and management of cardiovascular disease. And we present the Atlas highlights from the perspectives of the current status, challenges, and opportunities in cardiovascular care for women. We will conclude with 12 specific recommendations for actionable next steps to further the existing progress that's been made in addressing these knowledge gaps by tackling the remaining outstanding disparities in women's cardiovascular care, with the goal to improve outcomes for women in Canada. Before we start, I would just like to talk about the women that have supported us and have been involved in all of this work and will be presenting today. And these are in alphabetical order. Dr. Nadja Adriak is a trainee representative, executive steering committee, a clinical researcher at the Children's Hospital National CAPS Network Data Registry Coordinator of Pediatric Surgery at the University of British Columbia at the Vancouver campus. Dr. Jill Bruneau is an assistant professor, nurse practitioner coordinator, graduate programs at the Faculty of Nursing at Memorial University in Newfoundland. Dr. Tracy Colella is a clinician scientist, Kite Toronto Rehab, University Health Network, Cardiovascular Prevention and Rehab Program, associate professor at the Lawrence S. Bloomberg Faculty of Nursing, Rehab Science Institute at the University of Toronto. Dr. Martha Gulati prepared the slides and is up in the air actually trying to land, so she won't be able to be with us today, but she is the president in American Society for Preventive Cardiology and professor of cardiology at the Cedars-Sinai Health Institute. She holds the Anita Friedman Endowed Chair in Women's Cardiovascular Medicine and Research and is the associate director of the Barbara Streisand Women's Heart Health Center. Kira Lieblich is a fourth-year medical student at Queen's University. Dr. Carrie Mullen is the director of the Canadian Women's Heart Health Center at the University of Ottawa Heart Institute. Dr. Christine Pacheco is a cardiologist, Pierre Boucher Hospital and University of Montreal Hospital Center, and the clinical assistant professor, Department of Medicine at the Université de Montréal. Helen Robert is a patient advocate and person with lived experience based out of Ottawa.
I just wanted to reach out to everyone and say it has been just a wonderful opportunity to work on these 9 chapters and to amass the amount of clinical and research scientific-based evidence that we have for cardiovascular disease in women, and that this will make a huge difference going forward. And I just want to thank everybody on the faculty of this webinar, as well as all of my colleagues and all of our women with lived experience who have contributed enormously to this body of work. And I really am enormously appreciative. So take it away, team.
We're going to now turn it over to a recorded version of Christine Pacheco.
All right, thank you so much for that introduction. And I would love to thank Colleen Norris and Dr. Sharon Mulvey for being pivotal in the establishment of the Canadian Women's Heart Health Atlas, a document that I have had the great pleasure of working on in the last few years, and which is a pivotal piece that summarizes the state of women's cardiovascular health in Canada and is a very useful tool for our trainees and physicians to be able to find all the information they need in one location in detail with state-of-the-art reviews that summarize the latest data for women and their heart health. So today I will be talking about presentation, diagnosis, treatment, and prognosis of cardiovascular disease in women, which I have had the pleasure of writing about in this atlas, and for which you will find most of the following slides and information, chapters 5 and 6 of the atlas. We know that women are different in terms of cardiovascular disease when it comes to risk factors, We know that women with traditional risk factors have different risks according to each risk factor when we compare. This in our landmark document on the state of science in women's cardiovascular disease in Canada. Women are at higher risk for hypertension. They are most often diagnosed with a poorly controlled hypertension, and hypertension is a very important risk factor for developing stroke and heart disease. We also know that women with diabetes are at higher risk of developing heart disease than men, and women are prone to the effects of psychosocial stress and stressors, which can be triggers for certain disease in women. Furthermore, beyond traditional risk factors, we now have well established in the literature that female-specific risk factors exist, including hypertensive disorders of pregnancy, pregnancy loss, infertility treatments, and we also know that women have predominant risk factors in female predominant disease, such as systemic autoimmune diseases, as well as intersecting risk factors, which go beyond traditional or physically measured risk factors and include age, but also ethnicity, race, and gender. Clinical presentation of cardiovascular disease is distinct in women. We know that women most often present with a heart attack, for example, with chest pain. However, they might not describe it as chest pain. They might describe it as discomfort, as aching, and sometimes this may deviate clinicians from the right course of action. We also know that women present more likely with additional symptoms, including nausea, unusual fatigue, dizziness, and this might also sometimes confuse clinicians who are not aware of these differences in women, leading to less prompt diagnosis and treatment. Causes of myocardial infarction, heart attacks in women, are distinct. We now know that SCAD, spontaneous coronary artery dissection, is no longer as rare as we thought it was, and 90% of cases occur in women. This is a multifaceted entity which has different triggers, including exercise, but emotional stress as well, can be modulated by sex hormones. And all these triggers can lead to a spontaneous heart attack in previously healthy women. There are also underlying genetic factors, as well as underlying diseases, including fibromuscular dysplasia, which can be diagnosed in up to 30% of women. We also know that MINOCA, myocardial infarction with no obstructive coronary artery disease, occurs more frequently in women. And we now know that in order to diagnose women properly, we need to be careful and and be very specific and systematic about the way that we diagnose them, including a systematic overview of the testing they undergo, whether it be invasive coronary angiogram or non-invasive cardiac MRI, as well as different testings to get to the bottom of why women are having heart attacks that are unexplained. Differences between men and women also exist in terms of heart failure. Women are more likely to be diagnosed with heart failure with preserved ejection fraction as opposed to reduced ejection fraction. And women account for 90% of cases of Takotsubo or stress cardiomyopathy, which is an acute dysfunction of the left ventricle in either physical or emotionally stressful situations. Valvular heart disease is also often maybe underdiagnosed in women, and women have increased risk of complications following surgery for valvular disease. Finally, prognosis of cardiovascular disease is different between women and men. We know that women are at higher risk of mortality of major cardiovascular diseases, as well as ischemic heart disease, specifically younger women who are at risk of dying following a heart attack higher than their male counterparts. So next steps need to address these questions. Why do women die more from heart attacks or cardiovascular disease? And why are women not being diagnosed as promptly? And the Alliance continues to work towards this goal of improving cardiovascular diagnosis and treatment for women. Thank you very much for your attention.
Thanks, Dr. Pacheco. And so I'm Carrie Mullen out of Ottawa, the University of Ottawa Heart Institute, and I'm going to touch on access to care issues, which we addressed in a number of the Atlas chapters. In general, we are facing an access to healthcare issue in Canada. A recent national survey highlighted the issues in primary care access. 6.5 million Canadians are without a regular primary care provider in Canada. And you can see here the differences across the various provinces and territories. About 30% of residents in British Columbia, the Atlantic Canada provinces, and Quebec are without a primary care provider. And in Northwest Territories and Nunavut, about half to 3/4 of residents are without a regular primary care provider. Also a disproportionate burden in Canada, and this includes women, rural residents, Indigenous people, African, Caribbean, and Black people, and ironically, people with existing health problems. In Chapter 2 of this atlas, we presented the sort of disparities seen across Canada in terms of cardiovascular disease mortality among women. The age-standardized death rates for heart disease and stroke in women are highest in Canada's least populated provinces and territories, and lowest in our most populated provinces. And so we often think about geographic location when we think about access to care, but other things also impact our access. Things like the availability of resources, structural biases that might exist within healthcare organizations, and also knowledge and awareness. But women continue to experience disproportionate disparities with regard to access to best practice healthcare when they present for assessment of cardiovascular risk, cardiac symptoms, or established cardiovascular disease due to female-specific physiological characteristics, but also gender-related social dynamics, which play into some of these systemic biases that we see. So a couple of examples of access issues that we highlight, one around adverse pregnancy conditions. It's well established that women who've had a adverse pregnancy outcome, like developing high blood pressure during pregnancy, or developing diabetes during pregnancy, or having preterm birth, are at greater risk of developing heart and vascular disease risk factors and heart and vascular disease postpartum. And yet one report found that less than half of women who were identified to have had an adverse pregnancy outcome, putting them at greater risk, were actually referred for further assessment and follow-up. And we just heard from Dr. Pacheco the differences between men and women in terms of the presentation of acute coronary syndromes or chest pain or heart attack symptoms, for example. And even when women, and particularly younger women, report their symptoms as being heart-related, they're more likely than men to be dismissed by medical professionals. So some recommendations for action. We're going to hear more about clinical guidelines and systematic algorithms to assess acute coronary syndromes in women. There's a need for provincial and national health system strategies to incorporate postpartum cardiovascular care into existing primary care and preventative care models. And what goes along with all of this is better training, education, and awareness when it comes to differences between men and women around cardiovascular disease. Also important is, of course, research and ongoing research. So with that, to talk more about research, I'll pass it now to Dr. Tracy Colella from Toronto.
Thank you, Dr. Mullen. I'm Tracy, and I'm at Toronto Rehab. And I'm going to talk a little bit about the research and really overview what some of our recommendations are as a result of this, this chapter. Next slide, please. First of all, I just wanted to talk a bit about what this chapter means, or this atlas means. Being involved in the development of a number of the chapters in the atlas has been an experience that's truly reshaped my perspective on the epitome of interdisciplinary teamwork and collaboration. Scientists, clinicians, women with lived experience, and advocates committed to and passionate about making an impact and change for women's cardiovascular health in Canada and abroad. It's been very inspiring. This atlas, as mentioned, is the first of its kind, so it really provides a foundation which places Canada is a leader on the world stage and provides many experts with the ability to accelerate their research activities and disseminate knowledge of cardiovascular care for women. Considering Canada's population size and funding structure, Canada remains competitive in the global research landscape, despite the total limited funding dollars directed specifically to women's cardiovascular research. So global opportunities and collaborations are key to optimize the limited research dollars in smaller countries and opportunities for a global impact in cardiovascular disease. So definitely on our radar. And finally, we finish with actionable recommendations that will foster future work and change the future landscape of research for women's heart health. So it's been very inspiring. And next slide, please. The reality is that women in research, women still remain underrepresented and under-researched in clinical trials. So this is the downside to what we're presenting here today. We know that in recent decades, this complex mix of unders began in health research, where studies on middle-aged white male subjects have informed every aspect of heart health care for women. And we know that women differ physiologically, hormonally, gender roles, and we're not smaller versions of men. So this historical lack of equal representation of women in clinical trials has hindered the progress of understanding women's responses to medical therapies, interventions, and procedures. When clinical research doesn't incorporate representation of women or analysis of sex-specific differences, it presents a significant barrier to knowledge generation and the development of evidence-based guidelines. If there's no data, then recommendations cannot be made. So we need really to focus on getting more women recruited into trials so we can look at findings and data that is clearly representative of women's needs. So some of these gaps in knowledge threaten women's heart health approaches to prevention, diagnosis, and treatment. And not considering the unique female physiology or gender roles and identities is really doing an underservice for our women. Next slide, please. And not only is there a lack of women in research, but a lack of diversity. We have a large Indigenous population in our country, and as well, up to 27% of Canada's population are racial minorities that have higher risk profiles. And often the intersection of social and cultural barriers may impact their ability to participate in research. So it's our responsibility to really, prioritize women's heart health in research, and which is required to address these gaps and provide a foundation for change. Next slide, please. So finally, my last slide is really a call to action. And in our world, we envision the future where sex and gender considerations are part of all aspects of research design, execution, and reporting. And you can see we have action items here, 4 clearly outlined, that I'll just briefly touch on in order to make this become a reality. Targeted education and support. We need to invest in gender-based analysis and research training, as well as curriculum in all healthcare fields, so we can build capacity in the proper design and conduct of sex and gender-based analysis research, encourage the use of sex and gender tools, and really facilitate collaboration with sex and gender experts so we can help build that capacity for future generations. We need equitable representation where we adopt policies that require researchers to collect and analyze and report by sex, gender, race, and ethnicity where possible. Mandate for a cultural inclusivity and diversity. I've already spoken briefly to the equitable representation of women in research trials. We really need to improve that recruitment and look at strategies on how we can. Recent evidence from the Stanford researchers has shown that when female principal investigators lead studies, those studies are significantly more likely to enroll a greater number of female participants. So diversifying clinical trial leadership is clearly a need. We have made some strides. However, in the last decade, the problem is that the number of or proportion of clinical trials led by women has not increased. So this is a real problem that we need to address, and there's much more work to be done in this area. Advocating for change, one of the components that we really are trying to understand women's hesitancy to participate in clinical trials. We need to be able to understand the hesitancy or the fear and address these logistical and financial needs that may help facilitate women participating in clinical trials and research, and really try to target mitigation strategies so we have equal representation. The active inclusion of patients as partners on research teams not only adds to the context of the lived experience, but ensures that we are collaboratively targeting the questions that really matter to patients we serve. And finally, when it comes to funding agencies and scientific journals and conferences, enforcement of sex and gender equity in reporting guidelines, requiring that funding, publication, and scientific conferences account for these sex and gender differences. And we are seeing this in Canada with a lot of our federal agencies, that it's mandatory, but it needs to be widespread in journals, conferences, and this is something that we are starting to see change, but again, still much more work to be done. So thank you for your attention, and I'm going to turn it over to our next presenter, which I believe is Dr. Carrie Mullen.
Thank you, Tracy. And I'd like to thank Dr. Martha Gulati, who, as Colleen mentioned, is on an airplane trying to land right now. But thank you to Dr. Gulati for preparing this section on guidelines. Sex and gender-based analysis of cardiovascular disease treatment and management have been consistently under-recognized. And despite the urgent need, there are no sex-specific guidelines for cardiovascular disease diagnosis or treatment. And this is largely due to, as Dr. Colella mentioned, an under-representation of women and female patients in cardiovascular disease research trials. Next slide, please. And perhaps because of this underrepresentation of women, women are often considered a, quote, special population in our clinical guidelines. And this is an example from the 2022 clinical guideline for the management of heart failure. Next slide, where, again, the information about women were listed in a table of other special populations. And this is in spite of women making up 52% of our population. It was recognized in this guideline that healthcare system factors are a potential source of disparate heart failure care delivery and outcomes. Women are less likely to receive discharge instructions for heart failure, less likely to be referred to specialty care, and less likely to receive a heart transplantation compared to men. And if you'll just click forward one more, we'll show a table from this guideline that lists other non-ischemic causes of heart failure. And you'll see on this list peripartum cardiomyopathy. Importantly, this is a female-specific condition that can occur in the peripartum period. And as already mentioned, rheumatologic or autoimmune conditions and stress-induced cardiomyopathy or Takotsubo syndrome are conditions where the prevalence is higher among women compared to men. So again, considering women as a special population within clinical guidelines has to change as women make up a majority of our population. Importantly, done to inform cardiovascular disease guidelines has been done in men. And in some guidelines, there were no women represented in the trials that actually formed the basis of the clinical guidelines. Next slide. So finally, and I'll just have you click through all of these, in order to improve cardiac care for women, it's important that our clinical guidelines are applied equally to men and women, that we reduce gender bias in care, that sex-specific considerations are included in our guidelines, and where the evidence exists, we need to be adding these to our guidelines that inform the care that we're providing. We need to continue to follow metrics globally and see what is going on around the world in terms of these clinical guidelines. And as Dr. Colella already mentioned, we need to increase diversity in trials. That includes enrolling more women in trials, but also looking at other minorities or groups within our population, including ethnic minorities that are at increased risk of developing cardiovascular disease. And with that, I'll now pass it on to our next speaker.
So we've heard about all of these things, and I'm sure that everybody is probably about as angry as I am about these things. Since I was diagnosed with SCAD, spontaneous coronary artery dissection, in 2015, and I started to try to learn more about my condition and realized how little there was, I started asking more and more questions, and somehow just got caught up in all of these things and all of these initiatives. And, you know, since the early 2000s, when people started to raise awareness of this, there have been a lot of different campaigns put forward just to try to raise awareness about these differences and urge women to take urgent care, or urgent action, sorry, to lower their risk. Significant examples, obviously, are Wear Red Canada today, which we're all participating in, I hope, and the Go Red for Women campaign in the US. Next slide, please. Oops. So in order to solve a problem, we first have to acknowledge it. And Wear Red Canada continues to raise awareness and promote that broader acknowledgement of the problem. But then we need to understand the problem. And to me, that's what the Atlas does. It really brings the limited research together. It provides a full understanding of the scope of the issue and what we know, what we don't know. It all wraps it up into one credible resource for scientists, clinicians, and patients to learn from. So it makes it easy to dig through what's what and actually understand what we have to work with. The Atlas, as Dr. Colella mentioned earlier, was developed by a team of scientists, clinicians, and patients from across the country, all working together side by side to ensure a holistic and well-rounded documentation of the state of women's heart health. The process we followed in itself, I think, is a model for collaboration, successful collaboration in this space. Once we understand the problem, then we can begin to solve it. And in this way, the Atlas provides clear recommendations that really need to provide a springboard for change. Next slide, please. So I think we all can agree that women are complicated. I don't think that's a surprise to anybody. And in fact, as we've heard from other people today, that's been an excuse for exclusion for far too long. We might confound the results. We don't want to make our research too complicated, too difficult. Let's keep it simple. Maybe it's time to embrace complicated. I would challenge scientists and funding agencies to, advocate by doing your job well. If you can leverage the power of technology and collaboration to deliver more relevant and insightful research with direct clinical application for women, it might make all the difference. It might even help you get published and cited more often. I challenge clinicians to listen carefully, to believe what your patients tell you, to ask more questions, and read our Atlas. Just make sure you're up to date on everything that's going on with women's heart health. Embrace the idea that complicated doesn't mean that we're atypical or special, as we heard earlier in the presentation, or emotional. but instead maybe notice the trends of what you're hearing from 52% of your patients, and maybe raise those as research ideas with some of your scientist friends. You also must keep advocating for changes to the regulations and the standards to provide better support and treatments for your female patients. And lastly, as patients, we have to remember that our voice is not quiet either, and we need to amplify it a little bit more. As we heard earlier, I think Dr. Mullen started with the state of our healthcare system in Canada. And because we're really not where we need to be, and there are so many complicated issues here, patients and their support systems, their loved ones, need to work on this too. You know, I often hear, you know, well, it's not my responsibility to fix the problem as a patient. And I completely agree with that. But you know what? Here we are, and life's not fair. There is a need to look out for ourselves. We have to try to find the strength through our struggles to learn about our condition, to advocate for what we need, the tests, the diagnosis, the treatments, and participate in the decision-making process as best we can. If you're strong enough and you're willing, consider advocating a bit more broadly. Consider advocating now by spreading awareness in your community, helping others learn from your experience. Ask about and participate in research. We heard that throughout the presentation today, but how important this is. We have, for our voice to be heard, we have to be in the samples, we have to be in the statistics, we have to have our say. And so participating is really key. And also consider joining maybe a research team as a patient partner or a clinical improvement team. Say what needs to be said, provide your insights to help craft better solutions. I also say, you know, invite yourself to the table. So sometimes we just don't know what's out there. So ask about research. Ask, what can I do to help? And surprisingly, you might find a lot of clinicians and researchers will be like, oh my goodness, would you mind doing? So just go ahead, crash the party, invite yourself. And finally, I would say, if you need a formal invitation, consider this yours. To everyone listening today, consider supporting change by joining the Canadian Women's Heart Health Alliance. Thank you.
Hello, thank you so much, Helen, for sharing your experience. And I will extend the same invitation for all women with lived experience to join us. We are lucky to have you, and we can't do anything without your help and support. Your voice is heard, and the change, we can make it together. So I'm here today to discuss critical aspect of medical education that often goes unnoticed, the gap in addressing sex and gender-based differences. Next slide, please. Despite increased awareness, our medical school and residency program still lack integrated curriculum in this particular topic. While medical students recognize the importance of sex and gender-specific medical education, less than half of them report their medical curriculum provide appropriate training for clinical management of this issue. A recent sex and gender-based medicine faculty survey administered to 44 medical schools across both the US and Canada found around 70% of responding have no formal curriculum in this topic. Moving to residency program, we see a similar trend. While over 90% of residents acknowledge the importance of cardiovascular disease, risk, and prevention in women, limited training opportunities exist. In cardiology residency, for example, less than 1/3 of cardiologists receive adequate cardio-obstructive training during their residency, with significant lack of exposure to pregnant patients. This gap extends beyond medical school and residency. Shockingly, there is no specific education in women's heart health in Canadian nursing school, which is most concerning since nurse contact is often the first and sometimes the only healthcare provider interface for many Canadians, especially those in rural area. Next slide, please. This gap clearly needs to be met, as these are our future healthcare providers. Without adequate education, we fail them and our patient as well. So in order to bridge the gap in women's healthcare, we propose some ideas. So first, we need to create a core cardiovascular component in comprehensive women's heart health curriculum at undergrad level and postgrad level as well for all healthcare providers. This can be achieved by encouraging collaboration among medical specialists such as obstetric, gynecology, family medicine, internal medicine, and cardiology. It's important to conduct a joint assessment of core competence, provide postgrad faculty development opportunities, and offer continuing medical education course to ensure that healthcare providers are well equipped to address the need of women. Next slide, please. These recommendations are also highlighted in our recent publication, which will be included in the special Hair Heart Matter edition in the Canadian Journal of Cardiology Open. And I want here to shout out to Dr. Michelle Graham as well for her support for our mission. So we conducted a rapid review of academic and grade literature and surveyed Canadian university and other health discipline programs to estimate the extent of which sex and gender and women's cardiovascular health content is being taught within our healthcare professional programs. Our study findings are consistent with the previous estimate of sex and gender content in general medical education. And this highlights the substantial gap in women-specific cardiovascular training and education across our healthcare educational program, as over 40% of healthcare programs that participated in our survey do not cover women-specific cardiovascular health content in their curriculum. Next slide, please. However, there is a hope, and we are here at the Alliance making a difference. The Training and Educational Working Group of the Alliance have developed a Women Heart Health educational course, which are 9 accredited educational modules that cover important topics, including recovery and cardiac rehabilitation. Those are free and can be accessed worldwide, and we are now in the process of integrating them to our medical school and curriculum. As a starting point for national and global adoption, we conducted a pilot program locally called Women's Heart Health Curriculum, which is a 3-year longitudinal program offer formal education for women's cardiovascular health and cardio-obstetric curriculum for adult cardiology residency program at University of Ottawa Heart Institution. Conducting this pilot program locally will be a stepping stone for national adoption of the curriculum to all adult cardiology residency program across the country and internationally. It also provides opportunity to build capacity and transforming learning to other specialty. In conclusion, the gap in sex and gender-based medicine education are substantial. All our effort can be made, and collectively we can make a change. With that, I will pass it now to Dr. Jill Borney, which is Assistant Professor at Memorial University, and Kira Liblick, which is medical student at Queen's University, to talk about access to clinical care. Thank you.
Thank you, Dr. Edrick. So we're working on some new strategies in clinical areas to improve cardiovascular care in women. I'm going to talk about 2 of these strategies. Next slide, please. One is to ensure that we do a better job at predicting women's cardiovascular risk by considering the many unique risk factors specific to women. And secondly, I'm going to talk to you about a new tool that we've created here at the Alliance that allows nurses and physicians to take better care of women coming into the emergency room with chest pain or chest discomfort. Next slide. The risk for cardiovascular disease, as we've already heard, is for women in Canada the risk for cardiovascular disease in women is different across Canada. as we've already heard. To predict the level of cardiovascular risk in women, clinicians most often use a tool called the Framingham Risk Score or the Reynolds Risk Score to predict the chances of a woman having a major event such as a heart attack or stroke over the next 10 years. However, what this tool and many others do not consider are all of the factors listed here on the slide and that we've heard about already today. We've heard that sex or differences in female physiology, such as high blood pressure during pregnancy and menopause, can increase cardiovascular risk. Women living and working in less populous, rural, remote areas in Canada are dying from heart attacks and strokes at higher rates, as shown in the darkest shaded regions on these two maps. And Indigenous people living in remote and isolated communities with the impact of colonization and other known challenges, put them at increased cardiovascular risk. Certain ethnic and racial variations and people living with disabilities are disadvantaged in terms of their access to care. What we must consider is how gender intersects with all of these risk factors to increase cardiovascular risk. So we have some work to do to encourage the development of a risk prediction tool for women that includes all of these intersecting factors, and to validate this tool with women in Canada so that clinicians can more accurately predict the risk for cardiovascular disease in women across the lifespan. Next slide, please. At the Alliance, we're making progress in terms of creating clinical tools for women. Over the past year, we've created a clinical tool or algorithm to be used in the emergency departments by emergency physicians, nurse practitioners, nurses, and paramedics that highlight specific signs and symptoms of chest pain or chest discomfort in women and alerts physicians to order specific tests to diagnose and treat women in a timely and effective way. This is good news, and as we make great strides towards helping clinicians take the best care of women's heart health. Thank you, and I'll pass it over to Kara.
Hey there, I'm going to speak to two more strategies and recommendations from the Alliance on clinical care. The first is that we are recognizing that specialized heart centers for women have been increasingly recognized to improve outcomes for women with cardiovascular disease, and their emergence across North America is only a recent development. Next slide, please. No centralized registration or credentialing exists for these programs. In order to obtain a more granular assessment of Canadian facilities that offer cardiovascular care with a sex and gender focus, the Alliance recently conducted a nationwide survey of academic and community clinical practices. The Alliance is working to raise awareness around these programs and their positive impact on women's cardiovascular health. Note that these are all located in more densely populated, larger urban areas, and advocacy and education are key to promoting community-based cardiovascular care for women in more rural and remote areas. Next slide, please. Further, there are specific approaches for increasing cardiovascular rehabilitation, participation, and completion in women that we recommend. Next slide. The first is a systematic approach to referral, including the use of automatic referral at the time of acute care discharge for cardiovascular events. Next, offering alternative programming options such as home-based, virtual, and women-only programming. We also recommend a standardized triage assessment and algorithm supporting patients' allocation to program models. In terms of research, we call for more evidence for optimizing exercise programs specific to women and their health. Additionally, research around the use of digital health technology, which can offer potential options to overcome barriers to women's participation, as well as rigorous research and funding that prioritizes the systematic inclusion of women in all cardiovascular rehabilitation and secondary prevention research. And this will all only be possible with continued advocacy and investment in education and awareness campaigns targeting the general public and healthcare providers. Finally, we call for the development of women-focused programs, especially for certain cardiovascular disease entities that are more common in women or unique to them, such as spontaneous coronary artery dissection. Thank you.
Wow, just unbelievable the amount of work that has gone on with this atlas. I'm just overwhelmed at what we've been able to accomplish, and it couldn't have happened without all of the support that we've had from everybody who's on the call today. We have some recommended actions to address the remaining gaps in cardiovascular care for women in Canada. And it's interesting that we call them the remaining gaps because they're sort of the gaps that were there when we started, but we are making headway, and I'm so proud of it. So number one is to recognize and understand that there are sex-specific and sex more common cardiovascular risk factors and manifestations of CVD. And it's pushing to understand that, as someone mentioned earlier, women are not small men, and that we females have differences right down to the cellular level that have to be recognized in order for us to move forward with women's cardiovascular health. We do have to include multidisciplinary, collaborative, didactic, and clinical practice training, specifically addressing sex and gender in core curriculum. So in our undergraduate, postgraduate, and all of the medical education, actually to identify that there are sex and gender. And when we're talking about gender, we're not just talking about gender identity. This means gender roles, gender relations, institutionalized gender, factors that actually affect the outcomes in women's cardiovascular health. We need to develop and implement CVD risk prediction tools that include sex, gender, race, ethnicity specific components. And those factors will affect outcomes. And until we are doing those fulsome assessments that say, ask about when you started your period, how, at what age, and what were those cycles like, all of it is associated with vascular health and increased risk if you've had issues that were never addressed. We need to develop a national health system strategy for incorporating postpartum cardiovascular care. We have identified over and over in the last 10 years specifically that the postpartum cardiovascular care has to occur for women who have complications of pregnancy. There is a direct relationship between having hypertension in pregnancy or gestational diabetes, preeclampsia, and early cardiovascular disease. And it's not to scare anyone, but we just need to recognize that risk and prevent the early cardiovascular disease from occurring. And I always note that when I was a nurse, a baby nurse, we would tell moms that gestational diabetes, don't worry about it. As soon as the baby's born, you're fine, you're good to go. Well, we know that that's not the case anymore, and we have to make sure that women and clinicians are aware of it. We need to continue advocacy campaigns that increase the awareness of CVD in women, and things like Wear Red Canada. I can't believe how far we've come in our advocacy campaigns, and really getting at inclusive and culturally sensitive materials that we reach everyone in Canada. You'll note that the centers are not only in high population areas, they're in cities, and it's tough for people even near that city to get into the programs that are in the cities. So we really need to advance that. We need to utilize sex-specific algorithms that include thresholds for high sensitivity troponins. All of our measurements, even today, it was mentioned about the no women in the clinical trials that are used for our practice guidelines, but also our algorithms for things like our limits for high sensitivity troponins. We don't necessarily know what the right level is for a female body versus a male body. And so we need to improve on those. Next slide, please. So we also have to refer automatically and encourage enrollment in cardiac rehab by women who have experienced acute coronary syndromes or heart failure. And actually, it's more than that. It's any woman who's had any kind of heart event, because the cardiac rehab programs are so inclusive and holistic, and they don't just talk about the biological and the physical recovery. It actually addresses all of these other gender factors that we really need to address. In one of our studies, we identified that the question, what is your cardiovascular risk? What is your stress level at home on a scale to 1, was absolutely predictive of you returning with a second cardiac event within the first year. So cardiac rehab programs address those sort of issues, and every woman should be referred to cardiac rehab program. We need to perform mental health screening during hospitalizations for acute cardiac events. We know that depression and anxiety both are predictive of coronary artery disease or of cardiac disease in women. Women are 4 times as likely to have a depressive event after having had an acute cardiac event. And so mental health screening is paramount in the recovery of women. We need to use the specialized heart centers that we were mentioning earlier. We require the inclusion of sex and gender and racialized consideration in research. And this isn't just to have you address sex and gender, which, it's wonderful that it's been included in heart and stroke and Canadian CIHR guidelines for our research, but it's really paying attention to what are we addressing and how is it affecting the outcome and how are we collecting that kind of data. We need to increase the representation of female and patients and investigators in clinical trials. One of our students has done another assessment of the latest anticoagulant guidelines that were just produced in 2023. And there are some trials in those guidelines that had 0 females in the trial. So we really don't know that the guidelines are appropriate or the best evidence for females at this point. And finally, we have to develop Canadian guidelines with sex and gender specific recommendations wherever possible. And we keep pushing for it. And the CCS has been so supportive of us, as is Dr. Michelle Graham. All of this has really moved the train forward, and we're excited about where we're going. So basically, the summary of recommendations from all of this work addresses all these 4 areas. So clinical practice, we have to have sex and gender in the assessment, prevention, and diagnosis and management of CVD risk factors. We have to have clinicians understand that it actually affects care, and we need to pay attention to that. The research must include inclusion of women and females in CV clinical trials, and sex and gender-based analysis is imperative. Advocacy efforts, and we couldn't have gotten anywhere without the advocacy of our women with lived experience. And I point everyone to Chapter 3, which was written by the women with lived experience and called Stopped at the Gate. And it's informed everything that I do in our research to say, this is what they're telling us. We need to listen to this. It isn't just anecdotal that we're hearing that people are being turned away. Here's the evidence. And then training and education for all healthcare providers. And this involves all of us that are involved in academia and making sure that it's in our curriculum for anybody who's in healthcare. Next slide, please. So I just want to thank everybody that's been involved in this. In this last chapter, we summarized the atlas and highlights. These are the names of the people that have been involved. The bolded ones are the people who were involved in Chapter 9, but everyone has been involved along the way, and it's been such a collaborative effort. And going forward, it's our intention that this repository of critical information is contained in the atlas. It serves as evidence, but we also are going to make it a living document and update it with any latest evidence. And we need to thank the editor of CJC Open for their support of this opportunity, and of course, we would not be here without the CWHHA Secretariat, their support in getting us organized for this. Nothing would have happened without them. I just want to make a note too that we have a CJC Open has also got a special issue that Sharon and I were able to edit this month for Women's Heart Health. All sorts of people from our area, from the Canadian Women's Heart Health Alliance, have included articles in this. And 7, 8, and 9 are actually in that edition as well. We do want to hear from you. Any questions or comments? Here are some of the reasons what are some of the reasons you think women are less likely or first, last author or editor on? We've got all sorts of questions ready, but we would love to hear from you if you have questions. The calculator question above, what are the accuracy levels for women and men? And it's about, I think we're talking about risk calculators for women.
Maybe I can respond to that, Colleen.
Thank you.
Yeah, I put in the Q&A that in 2023, the American Heart Association published a new risk calculator that called Prevent, and it looks at risk between females and males separately. And I'm just going to put in place the article that looked at the validation of that in terms of the accuracy of the data. But, you know, there's many variables and you know, no risk calculator is perfect, but on a population level, it does give us a decent indication of the risk that an individual would have for developing heart or vascular.
And I want to add to that. I've been on a couple of groups, one led by Louise Plot, that's looking at the risk calculators for atrial fibrillation, and then we added sex and gender variables to see how much it improves the risk calculation of those. And it does, like the gendered factors. The issue is getting those into clinical practice, because as everyone knows, the clinician wants something quick and easy, and it isn't just putting that they're female into your risk calculator. It's the factors that are brought into it as well. So there's so much work going on in all of our communities looking at those risk factor calculators. And one of the things that gets me a bit nervous about that is we use risk adjustment. I learned, I broke my teeth on risk factor calculators, my PhD in epidemiology, and it is really more for population-based things. And so when you start doing risk calculations on everybody, you're going to miss the essence of the person that's sitting in front of you. And for females and women's health, not just heart health, but for women's health in general, it's really, really important that we understand all of the specific factors of this person that's sitting in front of you. So, you know, as I mentioned earlier, there's so much evidence coming out about the essence of the monthly cycle and the progesterones and the estrogens and all of the endocrine system that's involved that just ticks on. I think of it now, like from an AI perspective, as the most biologically beautiful algorithm that goes on in our bodies month after month after month, and no one pays attention to that. You know, I've said at conferences, the only thing they ask you is when was your last period, and that stops getting asked at a certain point. But we really need to know, did your period start before 11? Did your period start after 14? All of those are, in essence, really important, not just for vascular health, but for women's health in general. And so that assessment has to be included. So I'm just looking at the other questions here. We know men should take aspirin a day. Should women do that? The research goes back and forth. I have a really interesting response to this, and then I'll let other people step in. But I have a student that was looking at pain control for women who had an IUD. And I said, you know, when we started coming out with the pain control, basic analgesics like ibuprofen, women with childbearing age were not included in those trials. So let's go back to the monograms that for Health Canada for ibuprofen, and let's look at how many women were actually included in those trials for ibuprofen we're talking about. And there are some trials that had 0 women in them. So that's just for basic ASA and, you know, ibuprofen. So, you know, I think the jury's still out about, you know, the evidence is that no, for primary prevention, aspirin a day is not what we would recommend for women. But I think we really need to address all of these in women-only trials going forward. I don't know if anybody else has a comment on that. Okay. As a woman with lived experience, it's been very, this has been very helpful. It's very timely. I'm undergoing open heart surgery again and have to decide on a tissue or a mechanical valve. Are there guidelines for women on risks and long-term anticoagulation? It sounds like current guidelines have been for men. Helen, do you want to talk to the fact of like what we're dealing with right now? I mean, it is true that the guidelines are directed at men, but from a woman with lived experience, what would you do in this case?
Oh my gosh. I don't know that I would, honestly don't know that I have any real good advice there. I guess what I would look at is, I don't know, just trying to have an honest conversation, I guess, with my doctors about me and what the concerns I have are. And then
And
obviously
say, yeah, that,
watching it. So I know myself, I had trouble with aspirin after a while with stomach issues. And so it needed a conversation with my doctors to figure out what was the best thing to do here. And it's tough because, yes, you're right, they're working with standards potentially that are developed based on research done in men. But I guess for me, I wonder, you know, is that better than nothing? Right? Is that better? And it may be okay. It doesn't mean that it's necessarily a problem, but it also doesn't confirm that it's not a problem. So I think, yeah, I mean, I don't know. I mean, I definitely don't have the medical background here or the knowledge.
yeah, no, and not to put you on a spot.
But yeah, I mean, I would, if I had concerns and I was worried about how it was going to affect me, or if I've had experience with the anticoagulants affecting me in a certain way, like I would want to talk about whether it's dosage, whether it's maybe alternatives, and just see try to ask what the pros and cons are, like get that expert advice to be able to maybe make a decision that's best for me. That would be the best you can do, I think, in this circumstance.
And I think absolutely that's it. And say, you know, I don't know can you talk with your clinician? Can you talk to me about the evidence on what's best? And say, you know, I did hear that there weren't a lot of women in those trials. Like, what should we be doing together, right?
Exactly. And sometimes even their clinical opinion. So if they are seeing a lot of women and a lot of women are saying the same things, even though there's no evidence, there may be some, you know, clinical anecdotal, I guess it's still anecdotal, but it's substantial enough for them to say, you know, I've had a number of patients with this problem, and these are some of the ways we've dealt with it, right? So just really trying to open the conversation. And I think just going to say, though, that does depend on the healthcare provider also being open to having these conversations and being comfortable with a little bit of gray. And often that's not the case. That's not what we hear from women, is that, you know, the healthcare providers are, well, that's not in the standard. This is the standard. This is what we do. You know, it doesn't matter that there weren't women included in the study. This is the rule, so to speak. And so they live with that. So one of the challenges that a lot of women have is they try to have these conversations and they get kind of shut down. And that's got to stop. So any healthcare providers on this call today, try to just pay attention to yourselves. I don't think it's really conscious, but just try and pay attention to that and try and recognize that these people are making decisions on their life in some cases. And so you need to listen to us and you need to let us participate in the decision making. And your role as an expert advisor is really, really powerful and really helpful, rather than just someone who says, this is what you need to do. You know, take these 2 blue pills every morning.
And one of the best piece of advice I've taken it to heart with my own healthcare is bring someone in with you that's saying, well, I don't think you're answering her question. So then it's different than this relationship that you have with your healthcare professional, that you're not challenging them. You have a friend that's there that's saying, yeah, I don't understand that. Can you explain that to me again? And so you know, someone said, use your posse. And I think that's exactly what, you know, women should be doing.
Yeah.
Okay, are we getting close to time here? I'm asking our Melissa or
maybe one more question, Colleen?
One more question, it says. Okay, thank you. That's great. Oh boy, they're all hard questions. I want to respond to this in terms of participating in research. Do you need participants who have family history but are not suffering from any symptoms? We need everybody to be participating in research, whether you have heart disease. From a women's health perspective, we need to get all this data together. And one thing I want to say is that you'll often hear that, you know, women don't participate and we can't get them to participate. And I think that's on us as researchers, that we've really made a mistake on that we need to make it conducive and think about the context of women's lives. And a couple of things we're doing in our research program is we have some tests that we'd like women to get measured under, and we give them it's called the Jane app that says, these are the days that it's being done. You pick the day that you would like to come in. And instead of just giving a parking pass, we're giving Uber or a taxi, so that we have to do things to help women participate and make it part of their lives. Every woman I've ever spoken to that wants to participate in research, we just have to be able to make that happen. So don't blame the women, blame the system.
And just, if I could just add to that, Colleen, just for a second, yeah, like some of the logistical pieces, like the transportation, childcare, that really needs to be taken into consideration as well. Sometimes there's financial issues. And one of the things that I've been reading a lot about too is the fear and hesitancy of harm. Some, you know, especially in drug trials. So really spending that time in having a conversation, you know, and clarifying and answering questions. And like you say, it's really in our approach and the strategies we take in recruiting women into trials. So couldn't agree more. And it's on us.
Your feedback is really important to us, so please do complete the evaluation after the session. And there's an afternoon webinar at 3 p.m. Eastern Standard Time, chest pain in women in the emergency department. There's been incredible work going on at that, and that it's going to change practice for us if we start involving this kind of focus on acute coronary care. And, you know, just from the bottom of my heart, I want to thank everyone who's been involved in this. It was sort of a pipe dream of mine, and Sharon helped, more than helped, directed us on how to get it done. Dr. Sharon Mulvey and all of the staff at Canadian Women's Heart Health Alliance. It's just been a dream come true. And it never would have happened without everybody, the village, participating. I want to thank all our presenters today. It goes without saying that this work is such a collaborative effort, and we wouldn't be here without all of you as well.
Wonderful. Thank you, everyone, for your presentations. Thank you to everyone who's attended. The recording of this webinar will also be posted on our website, CWHHA.ca, in the next few days. And you will be receiving an email with all the links and resources that were shared today, in addition to some others that may have been missed. So please let us know if you have any questions. And again, we welcome your feedback. If you can complete the evaluation, that would be wonderful. Have a wonderful Wear Red Canada Day, everyone. And we hope to see you on social media. Post your pictures and have a great time.